Bismillah ar-Rahman ar-Rahim. It's my pleasure to talk about a new medication recently present in the Egyptian pharmaceutical market, the oral semaglutide, which is the first and only oral GLP-1 receptor agonist till now. What is GLP-1? GLP-1 is a peptide comprised of 31 amino acids, and there is a human endogenous GLP-1, and semaglutide is a human GLP-1 analog, because we are having a human GLP-1 analog and exenidine based GLP-1 analog. Semaglutide is having 94% homology to human GLP-1, and the T half-life is approximately 1 week. GLP-1 receptor agonists are human, like we said, human GLP-1 based and exenidine based therapies or GLP-1. The human is either weekly, like dulaglutide and semaglutide injection, and the once daily is liraglutide injection and semaglutide oral medication. While the exenidine-based therapy is either weekly, exenatide, or once or twice daily, which is exenatide, and once daily, which is lexenatide. This is the role of GLP-1 in type 2 diabetes. The GLP is normally present and produced by the intestine, and it is degraded into an inactive GLP-1. And if we give an exogenous GLP-1, or if we prevent the degradation of DPP-4 by a DPP-4 inhibitor, and this is the exogenous introduction of GLP-1 receptor agonist, we're going to have available GLP-1 receptor agonist in our body. These are the actions of GLP-1 receptor agonist. On the stomach, it reduces gastric emptying, leading to satiety. On the hypothalamus, will reduce appetite again and reduce food intake. On the pancreas, it increases insulin release by the beta cells, and it reduces glucagon release by the alpha cells. GLP-1 receptor agonists target many pathophysiological defects in diabetes. We are having impaired insulin secretion, and we find that GLP-1 receptor agonists produce insulin from the beta cells, especially related to meals, and GLP-1 will reduce hepatic glucose production. It will help reduce appetite by different mechanisms, and it decreases glucose uptake. GLP-1 decreases glucagon secretion from the alpha cells of the pancreas, and it has to improve incretin effect inside our body. GLP-1 receptor agonists are effective treatment for type 2 diabetes. They are still underutilized. Only 5% of the patients with type 2 diabetes are receiving GLP-1 receptor agonists, and usually there is reluctance to start injectable therapy. So if we are having a potent oral therapy, this is going to add to our management. The medical rationale for oral semaglutide, timely treatment of type 2 diabetes is needed to reduce the risk of type 2 diabetes, and many patients do not achieve the guidelines in spite of all available type 2 diabetes medications. And GLP-1 provide effective glycemic control, weight reduction, low risk of hypoglycemia, and cardiovascular risk reduction. Oral semaglutide may lead to more initiation of GLP-1 receptor agonist treatment. Earlier, patients will be comfortable with oral medications. The oral administration of GLP-1 receptor agonist was challenging because it is rapidly degraded by the stomach. If oral-based drug is taken with enzymatic degradation, there is also limited permeability of the previous GLP-1s and low oral bioavailability, so there is limited absorption. So how did they produce the oral semaglutide? The oral semaglutide was combined or co-formulated with a substance called SNAC. And this SNAC led to better absorption and better bioavailability of the semaglutide, the oral semaglutide. It increased bioavailability of oral administration. The quantity of SNAC per tablet is 300 milligrams. So it can be absorbed from the stomach mucosa, leading to good bioavailability of the oral semaglutide. Glycemic control, weight management, and cardiometabolic risk management must work in synergy in order to optimize type 2 diabetes control. Effective glycemic control is needed, so we have an oral anti-diabetic medication used for type 2 diabetes. Is it having the same efficacy like injectable GLP-1 receptor agonist or not? Sorry. And let's start with the PIONEER program. The PIONEER program is the research done on oral semaglutide, and we have PIONEER 1, 2, 3, 4, 7, 8, 5, 6, 9, and 10. PIONEER 1 was done versus placebo and diet and exercise. PIONEER 2 versus SGLT2 inhibitors. PIONEER 3 versus DPP4 inhibitors. PIONEER 4 versus GLP-1 receptor agonist, another GLP-1. And PIONEER 7, flexible dose adjustment versus DPP4 inhibitors. PIONEER 8, add-on insulin. And special population, PIONEER 5 on renal patients, PIONEER 6 cardiovascular safety, PIONEER 9 and 10 versus GLP-1 receptor agonist. And dulaglutide was done on Japanese population, so we cannot, discuss the results because they have special characters and special BMI. So we're going to talk about PIONEER 3. And PIONEER 3 is an efficacy and long-term safety of oral semaglutide versus sitagliptin in subjects with type 2 diabetes, and it was done on 1,800 patients, average age 58, for 8.6 years, long duration, average weight 91, and average hemoglobin A1C was 8.3%. And we have 4 arms, one arm with 3 milligram oral semaglutide, the other arm 3 titrated to 7 milligram oral semaglutide, the third 3 milligram titrated to 7 milligram, titrated to 14 milligram oral semaglutide, and the fourth arm was 100 milligram sitagliptin, which is a powerful DPP-4 inhibitor. Oral semaglutide showed superior hemoglobin A1C and weight reduction versus sitagliptin. For doses of 7 milligram and 14 milligrams, they produced -1% and -1.3% hemoglobin A1C reduction compared to 0.8% reduction in sitagliptin. The weight reduction for sitagliptin was 2.2 kilograms and 3.1 kilograms versus 600 grams reduction in weight in sitagliptin. Again, a greater proportion of patients achieved target hemoglobin A1C less than 7% and weight loss more than 5% with oral semaglutide versus sitagliptin. Pioneer 3 summary is oral semaglutide 7 and 14 milligram are superior in reducing hemoglobin A1C compared to sitagliptin, and all doses are superior in reducing body weight. They are known now to reduce body weight as a group, the GLP-1 receptor agonist, according to the latest EASD-ADA. GLP-1 receptor agonists are powerful in weight reduction. They have similar profile in safety, and the side effects of nausea will diminish by time in most patients with semaglutide. In a Pioneer program, there was consistent reduction of hemoglobin A1C versus all comparators versus semaglutide. Then semaglutide was superior in hemoglobin A1C reduction versus all comparators. And more patients achieved hemoglobin A1C less than 7% in all Pioneer program in the group received semaglutide versus the group received different groups receiving all comparators. Let me now shift from effective glycemic control to weight control. And there is weight loss early in type 2 diabetes, and glycemic control, like we said, together with weight management and cardiometabolic management work in synergy for the management of type 2 diabetes. And this is the weight reduction in different Pioneer programs, and there was weight reduction 3.7 kilograms to 3.1, 4.4, and 3.7 in doses of 14 milligram semaglutide. Semaglutide also reduced waist circumference in different Pioneer programs. In Pioneer 2 versus empagliflozin, it reduced waist circumference 3.7 centimeter versus 3. In Pioneer 3, reduced waist circumference 2.3 centimeter versus 0.6 centimeter in sitagliptin. In Pioneer 8, it reduced 3.6 centimeter versus 0.7 centimeter in placebo. We come now to the cardiometabolic risk factor control. We need to address elevated cardiovascular risk in patients with type 2 diabetes and to modify the cardiovascular risk factors. How to do the modification? These are the cardiometabolic risk factors need to be addressed. Risk factors for atherosclerotic cardiovascular disease or atherosclerotic cardiovascular disease, or heart failure. And the cardiometabolic endpoints in PIONEER versus comparator products. In PIONEER 2, we can find that semaglutide reduced hemoglobin A1C, reduced body weight, reduced blood pressure 5 millimeter, and let me say also that empagliflozin produced loss of blood pressure or reduced blood pressure 5 millimeter, reduction in total cholesterol and LDL, reduction of C-reactive protein also was noticed in empagliflozin, and waist circumference 3.7 versus 3 in empagliflozin. In PIONEER 3, there was reduction in hemoglobin A1C, weight, there was reduction in total cholesterol and LDL, and reduction in weight circumference, 2.3 centimeter. In PIONEER 4, SEMA versus liraglutide, there was better weight control, but let me here explain that the liraglutide was only 1.8, not reaching more dose of liraglutide. But there was more waist circumference reduction in semaglutide versus liraglutide. In PIONEER 7, SEMA versus CETA, again, hemoglobin A1C reduction, weight reduction, systolic blood pressure a little bit more, and less total cholesterol and less LDL cholesterol. So we are having better effect on cardiometabolic risk factors. Patients may be reluctant to intensify treatment. We have this difficulty in our clinics when we tell the patient that we have to give him injection, whether insulin or non-insulin injection. The patient may not feel comfortable. He may escape for a few months and then come to you again with worse diabetes control. So if we are having an oral medication, some patients may take this chance. 76% of type 2 diabetes prefer once daily oral versus injectable insulin. And in UK healthcare professionals, 3 out of 4 healthcare professionals in UK would prefer to initiate once daily oral medication. No dose adjustment is needed in oral semaglutide. In cardiac patient, it was safe. And in patients with renal or hepatic disease, no dose adjustment is required for patients with renal or hepatic impairment. In patients with upper GIT disease, titrating the dose from 3 milligram to 7 milligram to 14 milligram was quite comfortable to the patients. In elderly patients, no dose adjustment is required. This is the 3 doses of semaglutide, 3 milligram, followed by 7 milligram, followed by 14 milligram, and dose escalation is done every month. How to take it? We take it on empty stomach with a glass of water half an hour before the breakfast. Factors decreasing semaglutide exposure: food intake prior to dosing, it's not recommended. Increase water volume more than 120 milli, so we need to take up to 120 milli or a half a glass of water. And decreased post-dosing fasting time if we take it and we didn't wait for 30 minutes. In summary, let me finish with this slide. Oral semaglutide is the first GLP-1 receptor agonist taken by oral route. and it leads to sustained hemoglobin A1C reduction. It is superior to many oral anti-diabetic medications used for type 2 diabetes, with most people reach hemoglobin A1C less than 7%, and there is reduction in body weight by decreased appetite, by decreased hunger, increased satiety, and increased fullness, and there is reduction in other cardiometabolic risk factor like significant reduction in systolic blood pressure, C-reactive protein, waist circumference, and favorable changes in weight, in lipid profile, and early use may be recommended in those who can take the oral semaglutide. Thank you very much.